Next, I'd like to call upon stage Dr. Jagatram. He's a very senior cataract and refractive surgeon, and sir will be talking about intraoperative abberometry, the pros and cons of intraoperative abberometry. Over to you, sir.
First of all, I am thankful to Dr. Sri Ganesh and Dr. Supriya for giving me this opportunity to speak on intraoperative abberometry. Intraoperative abberometry, or we say opti-wave refractive analysis, ORA. It is a real-time analysis of the refractive error and aphakic lens power during cataract surgery and allow adjustment of the IOL power intraoperatively. Pros are increased accuracy in patient with myopia, increased accuracy of IOL power in patients with history of RK, LASIK or PRK. Confirms the IOL power and axis alignment and shows residual refractive error and avoid toric marking. Useful in patients with high expectations and anxiety. There are some of the problems associated with intraoperative abberometry. Not high accuracy in short eyes. It cannot be performed in patients if intraocular pressure is low. Cannot be performed if there is a central corneal opacity. Lead speculum will alter the corneal astigmatism. So patient fixation is must if it is patient is under GA. Although we have attempted in certain situations, then it is much more difficult. I will be showing some of the video clips how we can achieve, how we do this intraoperative abberometry. Here, this is some maybe more than 5-6 year old video where continuous curvilinear capsulorhexis phacoemulsification was done here. What I want to show that after completion of the phacoemulsification, how it is done. Sufficient viscoelastic is injected into the capsular bag, and this is we have to achieve this. That then this opti-wave refractive analysis, it will show. You have to catch reading. How much? So here, intraoperative power calculation showed that 21 diopter of IOL to be implanted. But we have compared it because we have done in every case other optical biometry pre-operatively and compared that how much is accuracy of this system. So here we intraoperative ORA was done, and then we placed multifocal toric IOL using Varion and ORA as well as. Here we know that what was the power, so power was selected intraoperatively. And then comes the next video, opti-wave refractive analysis. Why? Because accuracy is important. This is a child, 8-year-old child with congenital cataract. Here also toric IOL required for this child, but we also studied it by intraoperative abberometry. Removal of the cortex from the capsular bag, and then ultimately assessing that what will be the IOL power using ORA. Adequate viscoelastic into capsular bag, and then because child was under GA, so I did some fixation part by rotation, and it showed that 27 diopter. But why we put less? Because under correction, that adjustment you have to do. particularly in children. And then, but accurately, I think it will show that how much astigmatism will be, what will be the alignment. So here it is the alignment of the axis using Callisto. But at the same time, because aura was done in this case, we know that how much will be the residual power. It shows no further rotation required, and residual astigmatism will be 0.15 diopter. This is very negligible. And probably this is the last video here, cataract surgery in post-RK eyes. We have to plan the incision, where to place the incision, so that adequate space has to be there between the two incisions, where to place the side port incision, and then fematocapsulotomy and emulsification. And this is the side port incision. Main incision and side port incision, and then this complete femato part, and then we started with the phacoemulsification, removal of the capsule. Of course, phacoemulsification not difficult, but this is a RK patient where usually there will be residual hypermetropia most of the time. In this case also we did optical biometry and with the other this, but here what this aura suggested that power should be this is intraoperative abberometry here, and it showed that 31 diopter is required, whereas optical biometry that showed about 29 diopter, so it showed extra, and this was much more accurate than the optical biometry, because otherwise we would have received about 2 diopter of the hypermetropia. It goes toward hypermetropia side, not toward the myopic side. So lens is placed, but only power, IOL power we have to. So cataract surgery in post-RK eyes can be challenging, and flax and aura helps in precise surgical planning. So in conclusion, intraoperative abberometry is a newer technological advancement which is useful tool in patients with extreme of keratometry and where there is already RK or other refractive procedure done, or axial length problem, to ensure the optical visual outcome, which is optimal visual outcome in these complicated cases. Thank you very much.
Thank you so much, sir, for that very comprehensive talk on a very unique and different technology. Just that very few of us have access to such technology. Any questions, sir?
So I wanted to ask you, like, especially for post-RK eyes, the power, of course, will probably come out much better with it. What about toric calculation? Because, RK eyes are very challenging for if you have to put a toric, it's very difficult to measure. So is Aura a good tool for post-RK eyes for toric IOL implantation as well?
Yeah, we do in many of the patient, because here in this case, only few radial incision were there. But if there are 16 or more than 16, then there is a confusion. But if it is specifically say 8 incision, 4 incision or 12 incision, definitely we can go for even toric IOL implantation in these cases. Advantage of this technique is in a selective cases where we have already done biometry using the other IOL master and other of the biometric devices as Dr. Shreya discussed. But then we compare that how much will be the difference. In RK patient, usually it will come much more, say in 29 diopter it was by optical, but by intraoperative barometry it was 31 diopter. So we would have received a hypermetropia of 2 diopter. There were some advantages, but there are some problems also, that if there are corneal opacity, low tension and fixation problem. Although I have done in pediatric also, you have to fix it.
One practical challenge with torics will be having a library of torics for all powers, sir. So with spherical, we can still have a library, but with torics, it will be